Good morning, everyone, and thanks for having me. Sorry for the technical glitch. I think we couldn't hear me, and I couldn't hear also. Today, I'm going to speak about OSA surgery and in a resource limited setting and how I maximize the tools that I have so that I can use my theatre time effectively and really cut down as much time as I can, where I can, and in a very safe method. Um, so, just as a brief introduction, um, obstructive sleep apnea is characterized by episodes of apnea or hypopnea, and this is associated with a decrease in the oxygen saturation and arousal of a patient. And I put in this annotation from a speech, and it's just to sort of show that the science of breathing has been around for a very long time. And I think perhaps it's maybe a bit neglected, and we should be more cognizant of how much we breathe. And I hope, through the presentation, we actually see why that's, an important factor. So in childhood, early treatment is quite critical, and the reason for this is that if children are left untreated, little can be done to correct the situation later on. And as you can see, there's quite a lot of abnormal conditions that do arise from sleep apnea in childhood, and these range from quite a multitude of psychological symptoms as well as other physical symptoms, which can be quite troublesome. But this talk is centered more around adults and surgery that we do in adults. And it does not deal with any medical treatment. It's mostly about surgery. So in adults, there's daytime and nighttime symptoms, and it's quite nice to ascertain what actually troubles them the most, because that's where you're going to direct a lot of how you deal with what's going on and the problem. But some of the symptoms that they experience is daytime sleepiness, poor concentration, irritability, falling asleep during routine tasks. And this is quite a common presentation of patients. There's also nocturnal frequent visits to the bathroom. And I think a lot of patients think that as they get older, this is a common occurrence. But I think more than 3 times does seem to be a bit worrisome and disturb their sleep through the night. And then I think the biggest complaints that all of the patients come with is snoring and witnessed episodes of pausing of breathing during sleep. And that's quite scary for the patients. However, a lot of them live with it for quite a long time before they seek any medical attention. I put in this slide just to show all of the effects that poor sleep can have on the body. And I think the take home from the slide is that it can affect a lot of other organs apart from just not having a good sleep. And I think the misconception is it's really, I wake up tired. It must be because I'm busy and I'm stressed and things like that. But the effects that it has on the other systems in our body, we should really be cognizant that it does really lead to a lot of morbidity and mortality in the long term. But some of the risk factors and associations that we have with OSA is older age, and the prevalence of OSA increases from young adulthood. Male sex, this is 2 to 3 times more than females' obesity, and this correlates with their BMI. So as the BMI increases, the risk of OSA increases. The craniofacial and upper airway abnormalities also contribute to having a smaller airway, and this increases the likelihood of OSA. And then other well-established risk factors include smoking. Smoking can increase or worsen OSA if it's already established. Family history of snoring or OSA, apart from behavioral characteristics, which might be an open mouth, and generally open mouth breathing or environmental allergies and things like that. They can also have anatomical factors. And then other factors that contribute is nasal congestion, and this really increases the airway resistance and prevalence of OSA. Um, Medications and substances. And I think this is quite prevalent in a lot of the population that we treat. There are a lot of medications to treat other illnesses. And why I'm bringing all of these factors, to our attention is that these make these patients high risk and a risk for anesthetic. So when we sort of look at all of the factors that may cause or be associated with OSA and we're doing surgery, we need to think about how old the patient is, their comorbid conditions, um, any other anomalies that we might have, smoking, so environmental issues. Um, and then how do we make a diagnosis? I put in a report of a sleep study, but polysomnography is the gold standard that's used. And with medical aid funders, they generally do need objective evidence of obstructive sleep apnea, and they use different indices to determine the severity, and it's based on different things, and generally it's calculated. And I put this up just to have a look because we do get a report generally which gives us enough information to decide what to do with the patient and classify the severity. But in general, the sleep study is done with recordings of multiple other systems, like in the picture on the right, we can see that there's the possibilities of how many things can be quite a few, but that's not available all the time. But there are definitely a minimum and a maximum, which we do have, and we work these indices to make a diagnosis. I put in the slide because we need some sort of way of diagnosing sleep apnea. And whilst this might not be the only thing that we can use, this is currently the gold standard and an objective way that we can test the before and after results of what we do with manipulating the airway. The other tools that one can use is a home sleep apnea test. This is definitely more convenient and cost-effective way of diagnosing obstructive sleep apnea. Why it's in pink is because I definitely use it quite often. It's really easy. Patients will generally arrive at the technician's office, and then they get strapped with the machine. They go home that afternoon, and then they present themselves again the following morning, and the information downloaded, and then depending on what we find, they might get titrated after that or not. But this is definitely a much more cost-effective way of testing patients. Nocturnal pulse oximetry is used. It's not a very accurate way of looking or testing obstructive sleep apnea. We do generally need a little bit more information than just the pulse oximetry. However, if there is nothing else, and often in kids, there really is not too much else. So just having a record of their pulse oximetry overnight is actually useful in leading us to diagnosis. Questionnaires. These tools I definitely use because I also feel it's quite a nice way of making the patient understand how the sleep affects their lives and what we sort of aim to achieve, or the parameters that we're using to see whether we've improved their symptoms or not. And uh, I'm sure we all have favorites, and there's a lot of questionnaires out there. and one can use whatever they'd like. But it's definitely a tool that we can use, that's easily accessible and doesn't involve too much of resource. Imaging studies I don't regularly use. However, it can sometimes be useful in looking at why patients have distorted anatomy, especially after surgeries, and they may have other surgeries, or they may have other causes of airway problems like vocal cord palsies and stuff like that. So it may be useful in certain circumstances, but it's definitely not a routine diagnostic tool that I use. Um, Complications if sleep apnea is left untreated. I put in the slide because I think it's quite important to be aware of what happens if we don't do anything. And I think this is not something that's commonly associated with sleep apnea. Even with GPs and other medical or healthcare providers, I don't think many people understand that if we don't sleep properly, it really does affect a lot of the other systems in our body, and a lot of the systems that cause a lot of morbidity and mortality afterwards. And part of the reason I'm interested in the airway and these things is because I am of Asian descent, and a lot of Asians have a high prevalence of hypertension and stroke and cardiac disease and diabetes and metabolic syndrome. And you can see on this slide on the second sort of point and the fourth one, cardiovascular disease and cerebrovascular morbidity is definitely one of the complications that's associated with patients with OSA, as well as pulmonary hypertension, type 2 diabetes, fatty liver, gout, unprovoked venous thrombosis. And I'm leaving this for last, the neuropsychiatric dysfunction, because I think a lot of patients actually have these symptoms more than, the cardiovascular and metabolic and fatty liver, venous thrombosis may be later symptoms, but it might start with something that's more psychiatric dysfunction and then progress to other systems that are involved. I'd just like to mention a brief word on reflux, and I think I did say that I'm not going to talk about anything medical, but I do think it's really worth mentioning that we see this often, and we see signs of reflux quite often. And when we treat OSA, it's quite important to treat the reflux, and there's many protocols. Everybody has sort of a method of treating it. I usually involve the gastroenterologist quite early on if I feel it's necessary or if it's a really big patient. Um, Other than that, I would treat with the PPI, and I would titrate up, and then should I get no joy within 6 months, then I would refer on. But you cannot ignore that reflux does play quite an important role in managing OSA, and also in treating this patient pre and post operatively. It's quite important to make sure that you get the reflux under control. Um, so OSAS surgery complications. I put this in as the first slide before I get into the surgery. Um, it is airway surgery. There is manipulation of the airway. There's manipulation of multiple parts of the airway. So complications are quite important to be aware of and to know how to manage. In the first picture, this is my patient, and he had an anterior palatoplasty, and this is 7 days post-op, he came in with a choking sensation, which got worse over the night, and by the morning he couldn't breathe through his nose or his mouth, and you can see his airway is quite swollen. Fortunately, I was able to get away with the nasopharyngeal airway, and that's where I started. And he managed fine, and the swelling settled within 24 hours, and that was able to be removed. The picture on the right side of that is an actually nasal bleed, so it's epistaxis post-op, and this is a clot that was pulled out of the glottis. It's not my picture. I did get it from another colleague that practices quite a lot of airway surgery. Um, However, in this patient, it was a quite a morbidly obese female, and there was not much of space in her airway, and she bled, and they really struggled to intubate this patient, and she ended up getting a tracheostomy. In these patients, I have a very low threshold to intervene when there is some sort of complication. And as I alluded to, where I start nasopharyngeal airway, sometimes that's not always possible, especially because you manipulate different parts of the airway. And it's very scary when a patient can't breathe. It's very dramatic when they bleed also, because there's not many places they can put pressure on or see where it's bleeding from. It's very traumatic for their partners, because it often happens at night and wakes them up. So I think the take home message is that if one cannot deal with the complications and is not available after hours and is not set up for tracheostomy or cannot perform an emergency tracheostomy, then one should not be doing this type of surgery. And it's quite important to understand that when you can see the bleeding is quite a lot, and you've manipulated quite many parts of the airway, so getting establishing safe airway in a time of a complication can be very difficult. So experience is one of the things that do count as a factor when considering doing this type of surgery, because one should have some experience of dealing with a bleeding airway, especially if they've manipulated the nose and the palate and perhaps the tonsils. So it's quite important to have the setting which the patient can go to afterwards, which is appropriate, and that's either an ICU or a high care setting where they can be monitored and or be intubated or have a trachea that is taken care of. So with that said, complications do happen. These patients are high risk. As I've mentioned earlier, they have many comorbid conditions and they have many risk factors associated with their medical condition. So when we manipulate the airway, you should be very wary of the complications that could happen and have the setting to send them to and deal with it before considering actually operating on their airway. With all that said, what other surgeries that exist? So generally, site of obstruction is what will direct where we do surgery, and it's generally split into the nasal cavity, nasopharynx, oropharynx, and the larynx. The goals of surgery are aimed at improving or eliminating the airway obstruction that's causing these disruptions in breathing or in sleep or breathing during sleep. And there's different surgical approaches depending on what we want to achieve and where the obstruction is. it's quite important to mention, like I think at this point, that doing a single site surgery generally doesn't give the effects that we require, because an obstruction or airway obstruction occurs at multiple parts of the airway, and when we address one part without addressing other parts of the airway, it doesn't work as well. And also, when we decrease nasal resistance in addition to other parts of the airway, it improves the overall airway resistance, overhealing 2 to 3 fold as it would if we didn't include the nasal airway. So it's really important to understand that the nasal airway is really, really a big part of dealing with um, OSAS and OSAS surgery. And in the nose, we want to decrease nasal resistance. And then we look at other parts of the airway that we can manipulate. I will be talking about mostly what I do in the airway, and some of the other things that exist and I don't do. But it's just so to give an idea of how much can be done and really what exists. So with OSAS surgery, there's Pelegiopharyngoplasty, and I think this previously used to be known as a UPPP, but um, I don't think we do that anymore. It's more refashioning the muscular framework so that we get a different type of airway without with minimizing the amount of soft tissue that we remove. But the surgery involves removal of tissue from the throat, which is part of the uvula and part of the soft palate. It aims to widen the airway and suspend the palate in an anterior fashion. And tonsillectomy is essential as an initial part of this procedure, which is followed by either an anterior palatoplasty or an expansion technique. And that how we decide which technique to use is based on what we see when we do a scope, a flexible scope. So when we look into the oropharynx and we see that there's quite a baggy soft palate that's hanging down and below the tongue base, and we can't really see the uvula. That's the type of patient that we would consider an anterior palatoplasty, because that lifts the palate or the soft palate anteriorly, and it shortens the length of the soft palate. With the expansion technique, it is a little bit different, and I do have some pictures to show the details of what happens with the expansion technique. But uh, when we use that technique in patients that have lateral swellings and more lateral collapse, and often you might see a patient with these boggy soft tissue swellings on the sides of the oropharynx just behind the tonsil. And that's the expansion technique addresses those lateral swellings that contribute to the obstruction. Genioglossus advancement and tongue advancement, there's multiple different techniques. The picture on the right is showing it's showing a sling technique that is a combination of uh, maxillary mandibular advancement and glosso genioglossus advancement with the sling. There's multiple ways of doing this. I do not practice this. The morbidity is quite high, and they require a very high resource environment to look after. As you can see, it's quite a destructive procedure, and it's quite intense on the patient. And I do feel there are a few safer ways of tending to these patients. And I think I mentioned this earlier on with complications. With complications, I don't work in a setting that can tend to complications with this. We don't have a max vax at one of the places I work at, so it can be quite difficult. So be wary. Also, bleeding in these patients, definitely they have a very high risk of bleeding. And again, often the patients that that have OSAS and require surgery for it are high risk and may have comorbid conditions that may require anticoagulation therapy. So there's a lot to consider with the risks involved in doing this type of surgery. With maxillo and mandibular advancement procedures, this is done in conjunction with the maxillofacial surgeon, but it's aimed at lengthening the bone tissue, and this is again done by multiple techniques. One can use devices that stretch the bone. You can use plating devices. So there's different methods of doing it. I do not do these. The fourth one is nasal surgery, and I think I mentioned that it is quite important to always consider nasal surgery as well as palate surgery or oral surgery. So, nasal surgery, without doing nasal surgery, we don't have as much benefit. So, it's really quite important to consider ways to decrease nasal resistance. And I'll talk a little bit about that in one of the next slides. Tracheostomy. Tracheostomy as a treatment option or a surgical treatment option is really reserved for me for patients that have had other surgeries and they've not really responded to, or medically they're not amenable to airway surgery. And in those patients, tracheostomy is the safest option for them. And it allows unobstructed airflow with really minimal dead space. So the ventilation is quite good. And then there's other forms of airway manipulation, and that's with nerve stimulation. And I often have patients that actually ask me about this because they can buy it online on Amazon, where they stick on an electrode under their chin and they go to sleep, and it shocks them while they sleep. You can also get an implantable device that does this. However, the studies are not too convincing, and I don't do this. Um, Palate and tongue-based radiofrequency ablation. I do this, and I do think that it is a really good option for older patients, and these are generally in their 60s and 70s that may require airway manipulation or airway surgery, and it's really minimally invasive. And I do have a slide just detailing on how I do this and what I use. Nasal surgery and airflow resistance. Most of the resistance is located in the nasal passages. So septoplasty and septal spur removal is quite important if there's a deviated septum or a spur. If there isn't, and the patient has quite a good septum, which is supportive and has no deviation, and there's enough space, one can consider turbinate reduction because this will decrease airway resistance. If there's other causes of nasal obstruction, which may be nasal valve problems, or they might have been in an accident or trauma, or have had multiple nasal surgeries, or for whatever reason, don't have a functional nose, functional rhinoplasty is also an option which can address functional and cosmetic issues. But I think that's quite an extreme and a last resort. Again, that's a very high resource operation, and one needs to have a lot of things to do that. So if one is working in a place, which I do offer that, but it's not routinely a surgery I would do for OSAS. Turbinate reduction and septoplasty is generally the most common things I do uh, for OSAS surgery. The picture on the right shows a septum stapler. This is what a septum stapler looks like inside the nose, and I generally will use a septum stapler if I'm doing primary septoplasty, um, and not use stitches because it really has it really has decreased the amount of time it takes to close a septum. And this, sometimes it can really take a long time to get the needle in, and you might hit things on the side and things like that. And then I use the septum stapler. It generally takes 30 seconds to a minute to staple. There's 8 staples in there. I will show a few other pictures. The next slide is some videos. It might be a bit loud, sorry. So that's the staples on in the right nasal cavity, and what it looks like from that side without um, the flap that's opposed. And the video that I'm playing now is on the opposite side, which shows what the staples look like on that side. Um, and that allows a septoplasty to go quite quickly because closing the septum then happens quite easily. And then I can move on to the palate surgery and, decreasing that time for me really helps with patients on my list because then that means someone else has a chance to get operated. The technique that I use is I use the mucosal flap is stapled together using the intact stapler. The staples are inserted from anterior to posterior. Initially, I put in a anchoring suture anteriorly, and then I use sort of a L-shaped configuration using the other staples that's in there. And there's 8 of them, so I use sort of 4 and 4. Um, that's just a video showing of the septum stapler again. This is when changing one's practice from using what we traditionally thought, I think often we think about why would we want to do that? Because if it's not broken, why fix it? But for me, as I said, time saving was quite a big uh, factor when considering this. The second was there's minimal crusting, and as you can see, it's only over the staples or where the staples are. And by 3 months, excuse me, this is my patient, which I followed up. And I followed quite a few of them up initially when I started using it. This is 3 months after, and it heals really nicely. And I find that it does give the patients less casting than with a stitch. Apart from this, in terms of other complications like synechia and perforation and bleeding, I don't, in my experience and according to the literature that exists, they're pretty much the same as other methods of closing the septum. Um, just some of the pearls that I have to take home is if you're going to use the septum stapler, try it more than once because the first time might be a bit tricky. Insert it into the nose partially closed. That definitely helps getting in the blunted edges in without struggling. Remember the direction of the flow of the nose and um, initially use it on the opposite side of your incision so that you don't really disrupt your flap after you've put it into place. And think about theatre time and cost saving because that's really one of the big drivers that made me change my practice while still keeping it safe. In terms of oral surgery, I briefly spoke about the palato Pharyngoplasty, and in general, they include tonsillectomy and then either anterior palatoplasty or expansion and or all three of them together. So it can be quite big surgery if one decides that they're going to do all of them. And if if one does decide that, um, it really should be in a setting where one can deal with the complications because you can see if one does all of these things, it can if goes wrong can be quite disastrous. This is So I put in these videos to show that's using the coblator, uh, whether to do intra or extracapsular. These patients generally have extracapsular. I do tend to do a lot of, sorry, I do tend to do a lot of the tonsillectomy as an intracapsular just out of habit, but I do find doing it that way also decreases pain for the patients as opposed to using the coblator to do an extracapsular tonsillectomy. I don't know why that is, but that has been my experience. Um, this is just a reminder of the soft palate anatomy and what are we trying to achieve. The top pictures show like a beach chair and a rope and someone in a sling. And I think sling is quite important because we want to sling the airway. And in the picture on the bottom right, you can see the red blocks are sort of the parts that we try to address and the anatomical muscles that we want to manipulate to achieve a better airway or more open airway. And we need to bear in mind that we're trying to create a sling. So the direction in which we place our sutures should generally go in the directions which we see in the bottom right picture. This is an anterior palatoplasty of a patient that I did. And it's quite looks quite a simple and easy procedure to do. It is technically it is quite easy to do, but I don't think that's where the difficulty of practicing this kind of procedures are. It's managing the complications, and I think I've mentioned it so many times, but it's really important to have experience and know what to do when that arises. But from A, B, and C, we can see soft palate, a little box being cut. In the bottom left picture is one of my post-op patients from, I think that's about 10 days post-op. In the middle, the black and white, you can see it's sutured in layers underneath, and the sutures go in different directions. And the reason for that is because we want to create that sling type of effect so that the palate still maintains quite good function. Um, With systematic review, it's shown that anterior palatoplasty is favorable compared to other methods of surgery. And I think it's quite important to know why we do the surgery and what parameters we find important or I find important to guide me. And a lot of it is what happens pre and post op, how their polysonography scores influence really what I do with surgery, and anterior palatoplasty with nasal surgery on its own gives very, very, very good results. Apart from what I'm showing on the screen, there's multiple other studies that show many benefits with doing this type of surgery to treat mild to moderate forms of sleep apnea, enough so that they may not require any other therapy. And this is not only restricted to a sleep apnea machine or other forms of airway surgery, other therapy also in terms of cardiovascular medications and stuff like that. So I find that it does really improve the quality of life of these patients. The expansion technique, this is a little bit more advanced and a little bit uh, more manipulation of the airway in a lot more places. And again, if we can remember that we really want to sling the airway up and we want to manipulate the palatoglossus because that's generally the muscle that flops into the airway. And in this patient, you can see there is a bit of a floppiness over here, which we want to go away, and that's what we want to address. And how we do that is um, by suturing it to the superior pole of the tonsil. And generally, I find it takes multiple sutures. It's not one suture. You've got to do deep sutures also. You do generally to get some bleeding. And again, you should be aware of the anatomy and the vasculature. It's a very vascular area. Uvula has some functional it provides some function for us, especially with mucus dripping into our oropharynx. So removing the uvula is not advised, but using sutures to anchor the tonsillar bolts definitely helps with tightening the palate, and over time that scars and keeps the arch stiff. This type of surgery is technically also not very difficult, but you've got to have experience. You've got to see other people do it, and see how they deal with the complications as well. Because with this surgery, it can be quite disastrous, not knowing where you are in a bloody field. Radiofrequency ablation I use because it's a nice method of decreasing airway resistance in the palate and in the tongue base. The tongue base can also be quite troublesome in causing airway obstruction, and radiofrequency ablation is a nice way of decreasing the amount of soft tissue, and it's also technically not too difficult. It can be done in the chair. I generally do not do that. Um, I take the patients to theater, and you give they're under general anesthetic. You inject some local. There's special ones that you use in the palate, and you use the same one in the tongue base, and you provide radio ablation into the areas which you'd like. And over time, apart from seeing the ablation while you're doing it, you can see in this picture, there's on the top right, there's areas that are blanched, and those are the areas generally that are ablated, and that's how you know you've ablated enough. And you see the soft tissue contraction, but over the time, it contracts a little bit more. And this is quite nice for patients that don't tolerate surgery well, have many comorbid conditions that don't help with healing, or don't lend well to healing, and may have other complications from surgery or big airway surgery. This is really a very nice tool to use. There is only one company in South Africa that has this machine, and I think their name is Curas, or Curis. Again, the last word on complications. Apart from swelling and bleeding, which are immediate complications that are life-threatening, there are other complications that can happen later on. These two generally are very dramatic, and are the ones that really shake even the surgeon the most, because it can be life-threatening. And sometimes, like in the situation that you see with the bleeding airway, you don't really know where you are or what's happening, and you can't really find where the bleeding is coming from. And a lot of the time, when it comes from the top and sort of pours down, it is difficult to get control of everything without panicking a bit. So you need experience with seeing or having dealt with this, so that you can handle the situation well. You need the correct environment to put the patient in afterwards. Tracheostomy and nasopharyngeal airways are probably one of your best friends in this situation. Tracheostomy is generally temporary. It can be labor intensive, so it's really a last resort, but I have a low threshold, especially depending on what surgery has been done and how much of the airway has been manipulated. Thank you.
Thank you so much. That was a very informative presentation. I'd just like to ask, how many months after the operation do you do the questionnaires or survey to check if the symptoms have improved?
Usually 3 to 6 months, and then they get seen 6 monthly thereafter, because keeping nasal airway opened is quite important in maintaining a low airway resistance. So generally, if they've had tibonoplasty, they'd get onto some nasal wash, thereafter. And in the long term, they might require that nasal wash or intranasal steroids thereafter. So generally, they do follow up at least 6 monthly or yearly thereafter.
Okay,
And
thank you.
also, just in terms of reflux, they do need to monitor that. And I think because we've sort of manipulated the airway in that area, we're the advocates of treating that. So we should be watching what happens with their reflux and trying to decrease the amount of reflux medication they're on, so that they don't have it. Yeah.
All right, thank you. Any input from the audience?
With Yes, with epiglottic collapse, one needs to determine what's happened and why the epiglottis has collapsed, because that's maybe not the most common thing to happen. And I think depending on the patient circumstance, again, tracheostomy is initially, a definitive and safe airway in term to give enough time to investigate what's happening and make a plan for reconstruction, or if that is possible. So I think, in terms of getting a definitive airway, tracheostomy, and then investigation.
Thank you. Any other questions from the audience?
Yes, thank you, Lufunda here.
Yes.
Um,
You can.
Dr. Ramdhani, how are you?
Well, how are you?
I'm very well. The septo
Stapler.
stent that you use, yeah, the septo staples. What material are they, and do you have to remove them afterwards, and what do you remove them with?
No. So we don't remove them afterwards. They made with something that's similar to stitch material, so like rapid vicryl, and then they dissolve over time. Um, about I think about 45 days, I would say, before they disappear completely. Yeah.
Oh, brilliant. Okay, that's good. Thank you. Thank you very much.
Cheers. I do see a question on the chat asking about a lower bleed rate with intracapsular tonsillectomy and pain control. That is exactly why I use intracapsular even with these patients. And I do take the capsule away, especially around the borders of the tonsil bed and around the lateral edges. But centrally, I do leave a capsule because it does cause less pain for the patient. And I do feel that the edges are the parts that are floppy. And if I do the expansion technique, I will put in sutures in there, which will cause fibrosis anyway. So my poor patient, they often lose a lot of weight, and I'm just trying to help them out a little bit. Um,
Hello. Morning, everyone. Please, how do you manage like a multi-level obstruction when you do a sleep endoscopy and you find out the palate and the tongue base is involved in the obstruction? Do you do a stage procedure or you manage them at once? Thank you very much.
that is a very good question. Often tongue-based work, I would use radio frequency ablation. I don't really like to, or I would use coblation because then it's not so bloody in general. I generally will do multi-level work, so I would never do a nose without a palate or no a palate without a nose and tongue base. I would definitely do multi-level procedure, but I think it just depends on what's available in the setting. So if the patient's going to have nose and palate surgery, they need to go into an appropriate setting for monitoring thereafter because there's been a lot of manipulation of the airway. You're expecting a little bit of swelling, and you want overnight oxygen monitoring. So as much as I'd love to say I do everything at once, there's certain patients that don't allow that. And I quite recently had a morbidly obese a female who has a very short neck. She's got COPD and had a lobectomy. And with that patient, I did stage procedure for her. So I did her nose initially, and then 3 months afterwards, we did her palate and her tonsils, and 3 months thereafter, radio ablated the tongue base. And she's now about a year and a half afterwards, and she's quite well. So it's really centered around what you have available and the patient dynamics.
All right. Thank you so much. All right. End the meeting now. Thank you, Dr. Ramdhani, for that very valuable input on OSAS. Have a
Yes,
nice
thanks
day.
for having me. Bye.
Bye.